For years, women have been told that aging is inevitable, that feeling worse in midlife is just part of the deal. But the science is finally catching up to what women have felt all along. Recent research shows that menopause isn't just a hormonal transition, it can dramatically accelerate biological aging. One study found that during the shift from perimenopause to menopause, a woman's biological age increased by up to 9 years in just 6 months. Another study of over 2,000 women showed that the rate of biological aging doubled during menopause, with some women aging up to 20 biological years during this transition, which is so not fair. Which brings me to today's conversation. Joining me is Nikolina Lauc, CEO and co-founder of GlycanAge, one of the most advanced health tech and longevity companies in the world. Their technology is built on more than 20 years of research, supported by 40 million euros in European grant funding, and powered by the largest proprietary human glycome data set ever assembled. GlycanAge is pioneering a new class of blood-based biomarkers that don't just eliminate how old you are, they help predict age-related disease risk, inflammation, and resilience long before symptoms appear. Today, we're going to dive into what biological age really means for women in midlife, why menopause is such a critical inflection point, and how this data can finally give women agency over how they age. This is a conversation every midlife woman should hear. Welcome, Nikolina.
Thank you for having me. It's a pleasure to be here.
Yes, it's almost your bedtime, so I don't want to take poor Nikolina. We're on the opposite ends of the world. She's in Europe, and I am, the UK, and I'm here in Canada. So it's nighttime for her and it's morning for me. So I appreciate you doing this.
No, and I have a little. I'm losing my voice. I have a little bit of cold, but yeah.
So do I. So, hey, we can be croaky together. I'm just coming out the tail end of it. And so, yes, I have my voice is a little bit shot for sure. So, okay. So GlycanAge, let me just give you just a little history of my own little GlycanAge story here, because I have this little, dirty secret that I watch the Kardashians. Okay. I know it's such trash TV, but it's one of those it's one of the reality shows that I watch that I'm embarrassed to say that I watch. But last year on one of the episodes, all the sisters did a GlycanAge test. And I was like, oh my God, I want to do a GlycanAge test. And it was so funny because the one sister that thought that she was going to be aged much faster than what she's chronologically. She thought, oh yeah, I'm going to be so old in comparison because she doesn't eat that great. And she was, well, so she says anyways. Anyway, she ended up being in like the top 10 percentile in the world. She was like 10 years younger than what her chronological age was. And after that, I became obsessed and I wanted to do the GlycanAge test because I wanted to see, okay, are all the things that I'm doing in my life, all the hacks, all the healthy eating and the exercise and the supplements, like my obsession with health has been lifelong. And I wanted to know, is this paying off, or am I going to be, what if I'm 10 years older than what I am, chronologically? And I was super nervous. Anyways, just so everybody knows, I am 3 years younger than my chronological age. I wish it was more, but at least it wasn't over. So when I opened up the email to see what my results were, I'm like, oh, thank God. I'm like, that would have been so embarrassing if I had to go on air and tell everybody and all my listeners, oh, Karen's actually older than what she thinks she is. All my hard work. So no, I'm good. So there we go. There's my story of I want to be like the Kardashians and I want to have good biological aging. But before we go any farther, let's explain what the heck is GlycanAge, chronological age, biological age, because that's, I think, words that most people haven't heard. is
Yeah,
the
let's
whole
start
like
there.
what that means.
And I think just to go back to the Kardashians, actually they did an epigenetic age test, so it wasn't a GlycanAge,
Oh,
but
really?
biological age. And I think because the term can be applied to different biomarkers, it often gets confused.
Oh my
Um,
God. Well, I didn't know there was a difference.
It's common. I think we kind of put everything into one bucket, but actually aging is multifactorial and there's many different systems you can measure. But we have
Okay.
had some celebrities use it. So Halle Berry spoke about it on Instagram. She did a test. She had a great result. And then also
Was
kind
she
of
more than 3 years younger than her chronological
40
age?
like an age, and I think she was 57 at the time. So it was pretty, or 56. So don't quote me on it. I'm not sure
And
anymore.
and
Uh,
her biological was 40?
Yeah, that's what,
Oh,
yeah.
I'm not doing as well as I thought
And
I
then
was. Jeez.
Simon Sinek also spoke about it in the podcast. He did the test. So there are lots of people talking about it now. But it is different because we're focused on immune aging or something called inflammaging. And
Okay.
other clocks are looking at epigenetics, which is more how your genes have expressed through time. So all the environmental footprint, and there's differences to them. I won't go into them now. It's more on the type of measurement, the repeatability, then the connection to outcomes and how it applies to research and individual patients. But the one that we see is most impacted by hormones, the studies you were talking at the beginning, the 9-year acceleration from premenopause to menopause, that was our paper. So we observed that on the GlycanAge clock, it's actually a lot less on the epigenetic clock. Epigenetic clock saw, I think, a 6% acceleration in the clock, which is different. So the immune aging is a lot more severe perimenopause to menopause than some other modalities. And then the other study of it, you kind of having double the rate of aging perimenopause to menopause. There was our study with twins. So we studied 2,000 twins in the UK from the Twins UK cohort, and we measured them over 20 years, every 6 years to look at different things, but aging was one of them. And we would see that perimenopause or perimenopause to menopause was a key driver of accelerated aging in women. So that's all true. But it is modifiable. So that's the in that study where
That's
we
the good
saw that.
news.
That's the good news. So in the same study that saw the acceleration of 9 years, there was HRT as an intervention, and actually the women that were on HRT, it was a placebo-controlled trial. They didn't have the 9 years aging. So HRT prevented them, prevented the acceleration in immune aging. So there are preventive modalities, and I think
That's amazing.
finally, menopause and HRT are getting the attention, the kind of even the FDA changing the labeling on it. Finally, that's being corrected after and decades of kind of mislabeling over emphasizing risks that were not true from the trials that were published. That's being corrected because about 20 years ago, 40% of women, up to 40% of women globally, were taking estrogen, and then after the WHI study, that dropped to 4 to 5% globally. So that's generations of women that have missed out on the benefits of this therapy due to fear mongering over something that actually wasn't correct in the end. Um,
I have so many questions about that study. I just want to back it up and just be really clear about what we're talking about then. Like if it's not epigenetic, which I was strong with, what are we talking about then when we're saying GlycanAge versus chronological age or biological age versus chronological age? Because a lot of people don't even understand that.
So there's many theories of what aging is. So there's 12 hallmarks of aging. Now there's going to be more as they expand their understanding of biology. But one key driver of aging is inflammation, or something called inflammaging. So this was first coined as a theory 25 years ago. By an Italian scientist called Claudio Franceschi. So he was connecting that to health decline and generally chronic disease, because majority of chronic diseases have a common mechanism, which is chronic inflammation, which is regulated by your immune system. So when we look at glycans on antibodies, which is the analysis we run, they would regulate function of your antibodies. And your antibodies are the most prevalent protein we would have in blood, so they are regulating inflammation on a systemic level. And this is low grade. It's not inflammation from exercise or an acute infection or cold. That wouldn't change your GlycanAge in the short term. It's really this accumulating slow burn that happens with age, and then is different men to women. So for men, it's very, very linear. They move in one line as they age. And women do better than men prior to menopause. So their immune system is less inflammatory. And actually, we see that in pregnancy, they have very anti-inflammatory changes. So their GlycanAge drops all the way down to when it was in their 20s because of the special estrogen the women create when they're in pregnancy. And then after pregnancy, it all goes the other way, but that's a different topic. And then it recovers after hormones rebalance, after breastfeeding. So it's a very modifiable marker that we can measure up to a decade before you actually have health symptoms or an event. So when we look at cardiometabolic disease, we would see these glycan signatures change up to 10 years prior to getting a diagnosis or getting a cardiovascular event, diabetes, many autoimmune indications. So it's something that's telling us that our health is suffering because of something we're going through, which could be menopause, and it's time to act now before we actually have a problem in the future. So there are preventive tools to help us manage our health before we get into
So you're
crisis.
saying you can pick up if somebody is kind of headed that way long before they get there.
Correct.
So with heart disease and other aging, inflammaging, or diseases caused by inflammaging and immune system stuff, you can pick it up like way before it actually starts to show symptoms.
Yes. So
Is that correct? Okay.
Correct. So we started as an institute, a research institute 20 years ago, and we started something called the Human Glycan Project. So it's looking at, as we had the Human Genome Project, this was looking at this other part of biology, so the glycans, which change how your biology works after all the genetic epigenetic influences. So it would incorporate your genetic background. It would incorporate your epigenetic background, which is the environment you've had throughout life, and then change how your molecules function in real time in response to all of that information set. So it's a new part of biology, which also enables us to measure these things before we go into diagnosis, because majority of healthcare is focused on disease. So the moment we can identify which organ doesn't work properly, it gets labeled as a disease. But on a molecular level, this starts decades before it turns into a disease and symptoms. So that's the field of study. So we've looked at 300,000 samples so far, human trials, different verticals, healthy aging, disease cohorts. But when we have patients who are healthy and then followed over a couple of decades, we see how this transition changes through time. And in majority of the cases, we can see that specific glycan signatures change 10 years prior to symptoms and the disease. It can be general hospitalization, it can be a specific disease, cardiovascular disease, rheumatoid arthritis, many others. And I can share a whole body of research on that. We're just now publishing a paper of 23,000 individuals and 16 disease indications, and also looking at general mortality prediction and showing that this is modifiable with caloric restriction, with HRT, with therapeutic plasma exchange, and many other modalities. So it's not a fixed risk marker. It's something that we can actively measure and change.
Kind of like the epigenetic thing. It's like it's there, but it doesn't mean that you've got a death sentence. You can change it.
Yes.
With the right interventions. What about Alzheimer's and dementia? Are you able to pick up on that?
So there is some research on it, looking at Parkinson's particularly, and some Alzheimer's and general dementia. We're not pursuing that as clinical indications. We're focused on cardiometabolic disease because you're limited in what you can do,
Yeah.
especially as where we can't work on 100 things. We can study, so whenever there's grant funding, we can study, but
Yeah.
we can't commercialize until a certain point. But there was a really nice study with a twins cohort in Sweden in Karolinska Institute. So they had 600 something twins followed over a couple of decades, and they were looking at prediction of mortality and dementia, and it was quite predictive of dementia and mortality. So it is an indication that we can pursue, but the data sets are small. 600 people in a scientific term, it's quite small. We would need to do it in thousands.
When you guys were doing this, the other really large twin study, then, and you started to see, I mean, you and I were talking about this before we aired, just, like that you guys weren't expecting to see that perimenopause was when the inflammaging was starting. And so this was what you guys saw with that big cohort of people, was how many twins were there?
1,000 twins over 20 years.
Over 20
So we've
years.
in every cohort all around the world, we've done more than 30 something populations around the world. So different ethnicities, geolocations, everybody ages, or we see the same type of GlycanAging, but women are always different to men. So there is, and actually post-menopause, they have more aging than men. So they kind of accelerate above men, and then they move on the same line as they kind of join later on. But it's a crucial event for aging in women. And we didn't interpret it as perimenopause. We interpreted it as menopause because we saw that it happens around a certain age group, and we didn't understand menopause fully because you don't meet the patients. You're just going to see data points and dots on a screen. It doesn't tell you anything about the patient experience. And then 5 years ago, as we started to apply this in practice, we kept meeting women around mid 40s, late 40s, or early 50s, but still cycling, where we would, or especially around the 50s, we would ask, gently, are you in menopause? And we would get a
Very
very
gently.
and then we get a very direct response, which would be, no, I have a perfectly regular cycle. But then there'll be all of these symptoms, which are perimenopause. And you could have a perfectly regular cycle, but it's still happening over a number of years prior, because menopause is a retrospective diagnosis. It actually happens a year, it's classified a year plus a
So
day that you
dumb.
haven't had a
Yeah.
cycle, which is not very proactive. And
No.
then actually only post-menopause, the labeling on HRT is post-menopause. So there's sometimes in some women up to a decade or more where you're experiencing these perimenopausal symptoms, and they can be 100 different symptoms, and you're not getting any care. And usually you go appointment to appointment, and you keep getting something for your symptoms. So we've met so many women, and there's so many. So Halle Berry was misdiagnosed in perimenopause.
Yeah.
And I'm not going to talk about the misdiagnosis, but Oprah was misdiagnosed in perimenopause. She had palpitations, and nobody told her it could be hormonal. She went to 5 top cardiologists, and none of them could
Unbelievable.
identify the problem until she picked up a book and read about menopause. So
Yeah.
if this profile of people is not getting the proper care, then what happens to everybody else? And
Yeah.
there are so many stories. Some of them are members of our board where they haven't slept for 5, 6 years, and then finally they start HRT because now they have the indication, and they call me 2 weeks later like, I'm sleeping. I haven't slept for 7 years. So
Yeah.
it's incredible that actually we don't we don't have good diagnostics for it. And we see that
No.
inflammation or inflammaging is starting at the point that the hormones are getting dysregulated. And the problem with measuring hormones directly is they fluctuate on a daily basis. And usually you don't have the baseline from in your 20s, 30s of what was normal for you. And then
Mm.
the reference range is so broad. It's from normal is between 50 and 350. And
Yeah.
if you drop from 300 to 100 and you have all the symptoms, if you do your labs, they're going to come back normal.
Yeah.
And you're going to get an answer that there's nothing wrong with your hormones. And you're going to get a sleeping pill or something for the symptoms or an antidepressant, but you're not going to get HRT. And that's
So
that
sad.
therapy that makes a difference. Yeah.
Yeah, I mean, this is why I do what I do, and it's still, I can't believe how mad it still makes me hearing about it. Like 10 years I've been doing this work, beating the drum, trying to get the education and the truth out there to women. And then, just hearing you sit and talk about it, it's just like I get so fired up about it where I can't believe that we're not being told the truth, that we can't get help, that Oprah freaking Winfrey can't even get help. Like, what does that say to the rest of us common folk that doctors are not trained in perimenopause? So this is up to 10 years on average. I would say it's usually 5 to 8 years is now average for perimenopausal symptoms, which is the worst time for women. It's not the menopause years. It's the perimenopausal where they'll say that's when their symptoms were the worst. And it's not to say they're still not suffering in menopause. They absolutely do, many of them. But the perimenopause, it's like it's this forgotten, it's not even known. It's not even forgotten. There was nothing to forget in their world. It's just not even addressed at all. And like you said, they wait till you are technically 1 year without a period, then you're in menopause. Okay, now if you're lucky, you might be able to find a doctor that's going to go, oh, maybe some of this is from your hormones dropping, and maybe we could put you on some hormone replacement therapy. But I mean, I just had a woman in my group yesterday who is 43, has no progesterone, is suffering immensely. She's got anxiety, horrible PMS. She's not sleeping. And she went to a doctor 2 months ago and they put her on birth control pill. And she said she lasted 1 month and was like, what am I doing? And was like, no. And she joined our program. And now she's getting help with natural bioidentical progesterone. I'm like, look, you don't have a deficiency in birth control. You have a deficiency in progesterone, which is one of the most important hormones and how it makes you feel. And I said, you're going to notice a huge difference within days of using this. And it just, anyways, I'll get off my soapbox, Nikolina. This is about you, not about me. But I just get so worked up about it.
Yeah.
Clearly. Sorry, what were you going to say?
That it's about the woman on the other side, and yeah, it's every one of us. And luckily, I think this generation has a lot more awareness, and that's due to the advocacy you're doing and Louise Newson is doing and other clinicians in the space, which are finally changing the narrative. Because up until then, even any generation under, the fear of HRT is so strong that they're willing to live through all the horrible symptoms just to kind of avoid the risk factors, which are not even there because they've been misinterpreted for 20 years.
Yeah. What did you guys find in your research the age where you started to see the inflammaging kicking in because that you could correlate with the hormones coming down?
Very individual. So, of
Yeah.
course, it's between mid 40s to 50s, but for some women, it happens a lot sooner, especially POI. So, if they're going to go into early menopause. And then for some women, it happens much later. So, we have had participants in the study, and this is kind of an active one unrolling, where there was a lady who didn't stop cycling until she was 60.
Yeah.
And she's only now actually taking HRT, and she had pretty good GlycanAge, pretty good immune function up until then. So I think it's very individual. It's not, of course, there's kind of a general age, but it can accelerate with smoking, with obesity. So there's things that can kind of accelerate menopause. And then if things can accelerate it, probably things can decelerate it as well. We just don't really have good ways to measure it. And actually, there's no diagnostics for menopause. That's why we do it as a retrospective diagnosis.
And when it comes to the inflammaging part of it, is it in most women? Let's say, okay, if the cohort is the cohort that had no HRT, what was the percentage of those women that had higher biological age than their chronological age?
So it doesn't need to be higher than chronological age, it's the change. So it's from where
Okay.
you are, there's an acceleration. And then the average is about the 9 years. For some women, it might be less years. For some women, it can be 30 years. We have clients who, and actually the ones which have the best immune function when they're young, for some reason have the most inflammaging as they go through. We don't know why. It's a scientific question. Maybe something that gives them an advantage when they're young actually works as a disadvantage as they go through menopause. We don't know. But it is so. Inflammation, it goes into one direction. When we measure it in relation to hormone decline, it goes just up, unless you reintroduce HRT. So it can be a signal for perimenopause as well, especially from when estrogen is dropping. So we are now putting this through a regulatory framework to look at long-term concentration of estrogen. So this as a type of, I don't know if you know what HbA1c is, like a long-term measure of glucose, where you see
Oh, yeah,
kind
yeah.
of
Yes.
average of glucose levels for 3 months. This is similar. So glycans would modulate antibody function, make it more pro-inflammatory or anti-inflammatory. And there's a specific set of glycans. I think you remember them from the study as we were talking at the beginning, G0, that's very related to estrogen. So the moment that shifts into more pro-inflammatory, it is most likely in women around this age group related to perimenopause and hormonal decline.
Wow. And it's always estrogen. She gets such a bad rap out there, and she is the most powerful. It's always about the estrogen. It'll be like, oh, well, we age this much faster. Or we're more prone to Alzheimer's and dementia. We're more prone to cancer. We're more prone to autoimmune. We're more and it always goes back to because of the drop of estradiol. It's like that is such a powerful hormone in our body. We should not be afraid of it. And yet, so many women are. I had a woman yesterday who no estrogen, she was in her 60s, zero estrogen in her body. And she kept saying, but I'm estrogen dominant because I did my genetics and I'm estrogen dominant. So I probably shouldn't take estrogen. And I said, you have no estrogen to be dominant with. So what they're telling her is completely wrong, but it's these genetics. And I've heard these genetic companies say this. I've seen them snips on social media where they're going, oh, if you show in your, you can show in your genetic profile that you're you're prone to estrogen dominance or you don't metabolize your estrogen well, but they don't even say it like that. They just say, you shouldn't take estrogen replacement therapy. And I'm like, you guys, you're doing such a disservice. It should be, you don't metabolize it down this certain pathway very well. So you need to support that pathway. It's not, no, you shouldn't take HRT. Look at how important this is. Like from what you're saying is women are going to age on average up to 9 years older than their chronological age. So if I'm 45 and I'm not on HRT and I start losing estrogen, estradiol, I could on the inside be aging like a 55-year-old person. Like that is insane. And then for, like you said, for some, it's 30 years. So you could be 45, but you're really 75 on the inside.
Usually the ones that change 30, they would be in the young 20s prior to menopause, and then they would basically hit their number. We don't know why, but it's kind of as if they're really protected prior to this event, and then they rapidly catch up with age and sometimes go over as well. But that was interesting because we saw in the data the ones which were actually biologically much younger aged much more in the menopause transition, and we of course don't understand why at this point. But it's
I wonder if
also
it's the concentration of the hormones. Like if these women were just naturally had higher levels of estrogen in their body, and then when they lost it, they're affected that much more.
so I think
Just my theory.
we did look at concentration levels of estrogen in the study, and that wasn't the key correlation. I think it's
Okay.
because all of us are used to a certain level, and it's a combination of different hormones, and there's so many different types of estrogen that just if we, measure it as we do now, with the markers we have, it doesn't give us a full picture of everything that's going on. So I think that question is there won't be a super simple answer to it. But what was
No.
interesting, we did studies with men in a similar way. And we found that something similar happens if you block testosterone in men. So they have this big pro inflammatory shift. And generally, testosterone levels are declining, and it happens in much younger men. And if you give them back testosterone, but you block aromatase, which is a conversion of testosterone to estrogen, they don't have any positive change in inflammation. They actually stay pro-inflammatory. Well, if you allow testosterone to convert to estrogen naturally, they have anti-inflammatory changes. So it's not just estrogen in women, it's also estrogen in men. And that so it's
Amazing.
estrogen generally.
And when you say types of estrogen, so did you guys look at like estriol? Because you talked about estriol, but that's the pregnancy hormone that we produce a boatload of when we're pregnant. And so that obviously has a lot of the immune protection part of it is the estriol, and then estradiol, and then being the strongest, the most important, and then there's estrone, which is usually the more obviously inflammatory, so it's going to help make you inflamed. And they say when we hit perimenopause, menopause, and we start losing that estradiol, and we start becoming more estrone dominant, that's when the inflammaging can start kicking in, just from a hormonal perspective, what it's doing inside the body. But obviously that's probably what's also happening on that, like the biological level, we'll say.
Yes, so I think with the kind of routine clinical tools, the estrogen, it doesn't distinguish. So when you have the
Okay.
level, it doesn't distinguish the different types of estrogen. And I think in pregnancy, we of course assume it's the special estrogen, but I think I don't know even if there was a measure for that or not. It's just kind of no.
Estradiol does go way up too in
Yeah,
pregnancy. So it could be either. Yeah,
yeah.
either one of those ones. Yeah. Okay, so
But
we're not distinguishing between each of the estrogens.
So
No.
this is why the concentration in this study would not matter, because it's kind of different estrogens together in one measurement. On the metabolic changes, so we see that
Mhm.
obesity is a key driver of inflammaging, and there's a big metabolic shift that happens in perimenopause because exactly your body is trying to store that estrogen and create it in fat because it was used to having it from the reproductive hormone, but now it's switching to other mechanisms to preserve itself because we have estrogen receptors everywhere. So we see that that would be a negative driver of inflammaging. And of course, if you reintroduce estrogen, there's a big reduction in diabetes. There's a 26% on average reduction in diabetes on women on estrogen versus not on estrogen. And if you look at all-cause mortality, so women who start estrogen early, around menopause or before, let's say perimenopause would be ideal, there's
Yes.
the data is around menopause, they have a 40% reduction in all-cause mortality. So there's also
40.
heart 40. So we know that this is something that's gonna expand their lifespans and health spans. The data is already there because the studies have been done. The emphasis has just been too much on the risks which have been exaggerated, breast cancer in particular, which is not a risk factor if you're an estrogen only, for example. So it's not the estrogen which is causing the breast cancer risk. And in the studies, it was a different type of hormone that was used, synthetic hormones that were used 20 years ago. And maybe the synthetic progestogen was connected to some of it, but the increased risk was so small. It was really exaggerated to scaremonger against something which was I think there's also a political element of that, so I'm not going to
Yep,
go in. But
I
it was,
agree.
I think 20 years ago, the sentiment was different of kind of, and who was doing the advocacy for the drugs, the pharma companies, the physicians, the male physicians, they kind of made it as an anti-feminist, the way they were portraying it, because they were calling it kind of femme forever. So being kind of
I
young.
got the book, Feminine Forever. It's hilarious. Oh my gosh.
It had some of the right sentiment, but because it was so anti-feminist at the time, it
Hmm.
also triggered
Hmm.
the backlash,
Hmm.
the political backlash against it, which didn't serve the drug quite well.
Hmm.
But now, as the long-term data is out there and it's undisputable that it reduces all-cause mortality, that it reduces the number of chronic disease, we are starting to reevaluate that data and position it as something that most women should consider versus the 4 or 5% of women who are on it today.
Okay, so let me ask you this. You're a scientist. You're obviously extremely smart. You've been doing this. Your dad did this, and now you do this. So the GlycanAge thing has been in your family for over 20 years, correct?
The glycan thing has been in her family for
The
30 years
glycan
plus.
thing. Yeah, okay. The glycan thing. Okay. There's still a huge cohort of women who say, I'm not going to take HRT. It's unnatural. We're supposed to age. We're supposed to go into menopause. We're supposed to lose our hormones. I don't want to mess with that. It doesn't seem right, et cetera, et cetera.
Yeah.
What do you say to people like that?
Well, majority
Now
of
that
this,
you know what you know.
I think this is due to framing and then also how aging has been positioned for women. But every single disease, most chronic diseases we suffer from today are age related. So every time you're treating cardiovascular disease, diabetes, dementia, you're treating an age related disease, and it is unnatural to treat it. So I think that understanding aging as a driver of different diseases, and of course, losing your ovaries is probably no different to losing any other organ in your body. So we shouldn't treat it differently than we treat diabetes or any other disease. So I think that's something that needs to change for us. And because it was positioned in this way and it has a certain history, there's a connotation with it. But I think it's very different to, what would I compare it with? Plastic surgery. let's
Yes.
it's
Yes.
something unnatural, but this is a hormone that you've been producing your whole life. Your body is used to. You have receptors everywhere for it, in every organ, skin, absolutely everywhere. Your body is designed to have it, and when it doesn't have it, it creates it in fat. So
Yeah.
I placing it with the hormones we have now, which are body identical. So there's the same as the molecules that we produce, is the most natural thing we can do to preserve health with age and to delay all the diseases we're treating anyhow, but we're treating in a way that we're covering up symptoms and not treating the cause. And this is actually the cause of chronic inflammation. And then majority of chronic disease in women happens post-menopause. And that's not an accident. So I think that reframing will happen slowly, but
Yeah.
and this shift is happening already because the advocacy is led by women and them
Yeah.
coming out with their journeys and their experience and explaining how this has changed their life, which takes it away from something that pharma controls or is, let's say, male driven or dominated. Um,
And that's exactly my response as well when people say that to me. And it's like, okay, if you're 70 years old and you get diagnosed with heart disease and the doctor says, look, you got to go on this pill or else you're going to have a heart attack. Would you say, no, that's unnatural? I'm supposed to be aging. I'm supposed to get heart disease. It's the number one killer of women, and men. No, 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 doctor. I have to do this naturally. We would never. We would
Um,
never. So it's like, do you want to prevent what's coming down the pipeline or try to prevent? 40% is a pretty darn good percentage. What supplement, what diet, what biohack do we know of that can reduce all cause mortality by 40%?
Not many. Actually, I think this is the
No.
most robust evidence we have, apart from my studies and some very early trial data, which you can't take into large human population studies. This is the most robust evidence we have. And I
Hmm.
think there's also a difference in disease burden compared to men and women. So women would spend 25% more, 25%. So this is maybe 4 extra years with chronic disease compared to men, and they would usually have more chronic conditions compared to men as they get into the kind of last quarter of life. So there's a gender imbalance in disease burden. Men live a little bit shorter, but the extra years the women get are with a lot more disease and suffering. And I presume that actually with this reduction in disease and mortality, the HRT is the answer for that gender imbalance. That if
Yeah.
majority of women were on HRT, this extra years of disease and would not be there because we already have the therapeutic modality, which balances this out from a disease burden standpoint. Um,
Hmm. It also proves, this whole thing proves too that, you can do everything under the sun to be a healthy person and to age well. Let's say minus the HRT. Let's say you eat perfectly, you exercise perfectly, you do all the things, you don't drink, you don't smoke, you live out in the middle of nowhere. You will still have the inflammaging on the inside. And like you said, there's obviously things that speed this up or increase it, like obesity and unhealthy lifestyles, that's going to for sure age you farther along than the person that's healthy. But I always say you can't supplement, you can't diet, you can't exercise your way out of hormonal loss. And just because you are super healthy, that doesn't mean that you're not going to get the effects of hormonal loss, because none of those things bring back the hormones, and it's the drop of the hormones that's driving the biggest driving factor of the inflammaging. Is that correct?
Correct. Yes.
So I've done my own GlycanAge test, of course. And as I said at the beginning of the podcast, I am 3 years younger than my chronological age. Thank goodness. I really wish it was more, Nikolina. I was hoping for, 35 or something, but I'm going to have to work on that. And you're going to tell me what it is that I can do besides the HRT, because I'm already on HRT, to get that number even lower. And you've got a copy of my results. So I would love it if you would share screen with us. And for those listening, we will tell you what it is that we're looking at, and just tell us what it is, like how the results work, because it's not just, oh, here's your GlycanAge. You actually go through a number of different markers. So you tell us what's going on.
I'll share your report, but I mean, even having a lower age is fantastic. So you're doing well, and I think we
Thank
can also
you.
learn what you're doing to lower it. Or maybe we can just explain what the test is, or what we.
Yes.
So it measures inflammaging, or just kind of aging of your immune system by looking at your antibodies and the glycans on the antibodies that would make them pro-inflammatory or anti-inflammatory. And then that's a proxy for systemic levels of inflammation. And this is also very low grade chronic, so it wouldn't be affected by any acute infections, colds, all of this would not change your GlycanAge. If something is chronic and related also to aging, that would accelerate it. So let me share screen and go for your report. Now, can you,
There
oh,
you go.
I can't see you, but let me see how to organize it
Oh,
so we
I
can.
can see you and I can see my test.
All right, great.
So, yeah.
Great. So this is the professional report. So for that, you need a glycan specialist or a medical doctor to guide you through. And then we have a more consumer version, but I thought let's go into the more comprehensive one with this one. And then you have all the different insights. So one is the biological age, which is predominantly related to inflammaging or proxy for immune aging. And then you have all the glycan indexes and insights, and an action plan, which is here generated by AI. But then as you have the consultation, it goes a lot deeper as we learn also about your health profile, because we can only, the more comprehensive picture you have, the more personalized the action steps can be. And then you have all the indications. So these are associations. We spoke about this at the beginning. Think of it as something in between genetics and potentially decades away from a health problem, but they're partially encoded in genes. And that's from 30 to 70% depending on the type of glycan. And your overall aging is also 40% heritable. From a glycan perspective. So part is your parents, but then everything else is the environment. And we've done
Right.
that
And
with
so with And I'll just do it quickly. So it says glycan insights. And so it's, pre-hypertension, hypertension, coronary artery disease. I won't list all of them, but type 2 diabetes, Crohn's disease, COPD, perimenopause. And then we've got influencing factors where you go through diet, stress, sleep, exercise, weight loss supplements, cycles, pregnancy, perimenopause, HRT, etc.
Right. And we can also go through some of this and we can look at them in line with your results. And then you have the little science 101. So I think maybe on that we can start with one part just to distinguish this difference between, it's a technical term, but glycation and glycosylation. Because we're often confused with glycation markers, which would be basically damage to your proteins by simple sugars. So HbA1c or A1c in the US, you would call it. This is completely different to that. So this is a post-translation modification, meaning partially it's encoded in your genes, and it's a complex trait that has nothing to do with this random damage of simple sugars. But we are looking at complex sugars. So the kind of the science of complex sugars is a lot less publicly popular, let's put it that way.
Okay.
Okay, and these are all the intervention studies we've had so far. So metformin, TRT, and a lot of them are currently in the making. So your results, these are great. So you're doing really well. Part of it,
Thank you.
again, thank your parents, but a good chunk is lifestyle. And maybe we can start there. Maybe if you would tell me a little bit apart from HRT, and even with HRT, is it what combination of hormones is it? Is estrogen, progesterone, and testosterone? Or if you can tell me a
Yep.
little bit more about, yeah.
I do all three, and melatonin and DHEA
Okay.
and
Amazing.
pregnenolone sometimes.
Okay,
I got all the hormones.
great. And in terms of lifestyle habits, how often do you exercise? What is your diet like?
My diet's great. My exercise could be better. I do exercise, but on average, probably 3 days a week.
Okay, that's not
Do
too
you
bad.
do you
I think,
find that there's a lot of people in the optimal range? So I'm kind of right in the just above halfway for optimal, but I can see that there's room to be a lot better. Do you find that a lot of people do end in that high end optimal range?
yes, so it depends which data set we're looking at. So if we're looking at the average population, then they're 9 years older or 9 years younger, if we could look at the good range, or the average is their age. The average GlycanAge user, the last time we looked at it on as an average, is 7 years older. So you are a little bit around that.
Yes.
So these
Okay.
are the health conscious, proactive, doing all the right things. So with the 3 days of exercise, what type of exercise is it?
Lifting weights, and then so I lift weights usually 3 days a week, and then I walk a lot throughout the week. So usually 3 or 4 days a week I'll walk too.
Nice. That is a good amount.
Hmm.
And in terms of diet, or maybe before I probe you, because we're gonna keep it short, what do you think is the main area that you would see room for improvement?
Cardiovascular.
Okay. All right, that's very interesting. Okay, we'll get
It
into
is
this now.
because I have an issue with cardiovascular on my GlycanAge,
Okay,
don't
yes,
I?
and I have this. All right, so let's then go through this side first. So these are the indexes, and this simplify your glycan profile. So they put the glycan species which are similar into cohorts. And the two that are driving your GlycanAge are youth and mature. These have the most weight for aging. So they would be, the ratio between them is really important, also for immune resilience. And the shield, it can change a lot with supplementation. It's the most anti-inflammatory one. That's the one that would go up if you were getting immunoglobulins from young people. So if, I don't know if you heard of IVIG, but this is this kind of having, how would you call it? So immunoglobulins from a young healthy person going into an autoimmune patient, which then make them anti-inflammatory, and is probably the most natural way to manage some autoimmune diseases versus the kind of harsh therapies. And the one that mostly responds to hormones is mature. So as you're transitioning from perimenopause to menopause, the whole glycom changes in a negative way. So actually, you're doing really well for the perimenopause cohort. And I would assume you're probably perimenopause, or are you already postmenopause?
I am postmenopause, but just as of recent.
Okay.
Like this year, I went into menopause, or at the end of last year.
So if we look at perimenopause, and that was up to this period, your entire glycom is changing in a pro-inflammatory way. And we really see that it's this main aging event in women, and it has a systemic effect on pretty much every system, cardiovascular, and all the risks of disease go up, as you know. So for this cohort of women, you are doing amazingly, because usually we see acceleration at this period, and you're under your age. So this is well managed with the therapy. And then maybe, so I don't need to go all the way up. Let's go on to
It was
HA.
in the ninth. So for those that aren't watching, I'm in the 19th percentile for anti-inflammatory glycan mature, right? Is
Yes,
that how you say it?
correct. So this is the one that changes the most with exercise. Oh, sorry,
Okay.
with HRT. So that's the effect of the therapy. So you can see here in the studies, these are really nicely designed, placebo control. The average woman's aging about 9.1 year in the menopause transition. But if they're put on estrogen, this can be mitigated, and the strongest effect is on glycomature. So that's the part you see in the report, and it will be the part that our specialists will dig into first.
So
So
amazing. For me, that's just proof. It's like, yes, I I wanted to see that. I wanted to see that, all of my efforts are paying off. And I love that it is. And it's like, yes, I'm doing the right thing for my body. I'm not aging 9 years older than my chronological age. And I'm almost at the high end of optimal. So that makes me very happy.
yes, you're also doing really well on this one. So this one is a little bit actually more complex to interpret, because sometimes it is linked to cardiovascular health, but in your case, it's not the whole group of this glycan, it's just one element of it. And this one responds really well to exercise. So there's
So I'm doing
that,
okay there.
and it is quite genetic as well. It can be up to, depending on structures, up to 70% genetic. And this is the one we call sleep, stress, and smoking, for former history of smoking, where you're also doing quite well.
Good. Yeah, I
Well, I
don't
don't,
smoke, so
yeah, and sleep or stress wise, how,
not that great.
not the, okay.
So I'm
So,
surprised it's not worse.
yeah, okay. So now this one here, the main associations, and this is in the advanced report, so maybe your first report doesn't have it, this one does. The primarily one is myocardial infarction, and sorry, I had influenza
It's
last
okay.
Mm.
So that's yeah, so that's where I'm definitely having more problems than not, and I've got the red flag for insights. It says cardiovascular health slightly out of range, but then for my metabolic, autoimmune, respiratory, and female is all optimal. Just so for those that aren't watching and listening.
And maybe you mentioned cardiovascular health at the beginning. Is there a family history? Is there
Mm,
no?
there's no heart attacks in my family. No, nothing like that. Actually, my father and mother, like in such good shape. Both of them have amazing cardiovascular health.
And did you mention it purely for the GlycanAge, or was this connected to something in your family history, in your personal history?
Like the cardiovascular health part. Yeah, I just don't feel like I get enough cardiovascular. Like I don't ever get my heart rate up where it should be unless I do my Carol bike, but I should definitely need to do more cardiovascular stuff.
Okay, so
I
this
just
is
walk.
strength training and walking. So I
Yang
can,
training and walking.
so let's then go on to this one. So this is actually just one of the glycan structures, which is part of glycan median, but you have most of them optimal. So there's only one which is abnormal here. And now this is also is an association, so it's not predetermined that it will cause any health problems. And this is based on the cohort we did here. This was a German cohort, so 2,000 participants, and then we had 400 cases of heart attack and stroke. And this is within the biobank was 30 years old, but I think this is a 10-year follow-up, but I would need to open the study to double check. So this is where the association came from. It's a study. And then there's a recommendation of blood work that you can do as a follow-up. You might have already done some of these and you might have
Yep.
some insight. Yeah,
Yep. Yep.
that was all good.
Everything was good except for I have a slight elevated bilirubin and ferritin. So that's which means that I'm inflamed if my ferritin is high. And the bilirubin was only 1 point over the top of the range, but bilirubin has to do with liver function. And we're trying to figure out what's driving that because I've never ever had those problems before. And so it could be a migraine medication that I take and that has something to do with that. We're not sure. So I'm just following it. And because I don't drink, I don't have any reason for my bilirubin to be elevated because of my lifestyle. So maybe that's why it is what it is on here. But my blood pressure's always on the low side. And then I've never done any sort of cardiac echo test or anything like that.
Have you ever done a genetic test for hemochromatosis?
Yes, and I don't have
No.
hemochromatosis.
Okay. Yeah,
Mm-mm.
yeah, interesting. Um,
Mm-hmm.
so, and when you measure ferritin, is it continuously high, or was that just on the one blood test that you've done?
It was continuously high now for the last year. Prior to 2 years ago, it was always on the low side. And so it was indicating my iron status. Now my iron's fine. It's the ferritin. It's just ferritin. So that tells me that that's being driven by inflammation.
Yes, and I actually, not especially so you would have to check if it applies, but blood donations is usually a way to manage iron storage. But yes.
But only if it's being driven by iron, if it's a high iron store, and mine's not. My iron's good. It's just the ferritin that's high. So then you could donate blood and it would reduce it, momentarily, but then it's going to go back up because we haven't got to the root of the inflammation.
Okay, it's very interesting. And in that
Hmm.
last, that it changed, did anything change in medication lifestyle?
Yes, it did. Yeah. So I started a daily migraine medication. So I'm thinking that it has something to do with that. I'm not sure though, because it's not like there was a little bit of evidence that showed that it can be hard on the liver, the medication. So I don't know. I'm still trying to figure it out.
Yeah, very interesting. Okay,
Hmm.
so
Hmm.
um, okay, so what we do have on this one, especially peak 22, is that it does respond positively to exercise. And let me just find a study on that. Um, and it was one specifically that we've done on women. So let me just see in which category. Okay, let me go back up. Okay, over exercise, this one. Okay. So this we call it cardio health, but actually peak 22 is the main association here, and they would improve. They were followed over 12 weeks, about 400 subjects. They were all female, and then there was different type of exercise, and all of it affected it positively. And I don't remember the proportion of this, but if you would increase your exercise, then this would improve that particular glycan, which is abnormal for you. So what we could do, you can start a new program and we can assign you a specialist for that, a sports scientist, and we can follow you every 3 months to see if it's improving that particular glycan.
Yep.
And if it's related to a lifestyle, it will change, and then that's the one that could have some future associations. If it's related to medication, it might not change.
Yeah.
So
Yeah.
maybe the variable to focus on.
Mhm.
Okay, yeah. That's a brief summary.
Yeah. No,
Um,
that's good. That's probably um, where we can leave that because I'm sure that people don't need to hear the rest of it because the rest of it's good. Nothing else was flagged except for that one. So it looks at all of these things, and so it's not just about your biological age. We're also seeing the impact of all of these other interventions on your body and what it is that you need to get help with. And then the kit itself will come with an appointment with somebody that will walk you through the results and what it is that you can do, correct?
Correct. And this will be assigned, there's a health profile you fill out alongside the testing. And then based on the main problem area, you'll be assigned a specialist. So if it's room for optimization around exercise, or if it's nutrition, a clinical nutritionist, if it's a health condition, then it will be a medical doctor who has training in glycosides.
How reliable are these tests? Like, are they like this is an exact science, or is it because it's been around for a while, hasn't it?
We've been so our first publication was 2013 on the biological age, and we started in the space of glycomics. We did the first large study of this in 2006, so it's been a while. And as you can
Yeah.
see, we have over 350 peer-reviewed papers. Some of them are referenced in this study, and all of this is based. So nothing that's in the report is invented. All of it is based on science that's published, peer-reviewed. You can click on the link, read the study, and we're very transparent about how big it was what was the impact, and then it's up to, in this case, this would be for specialists to interpret it and make an action.
It reminds me of like the benefits of doing DNA testing, where if you do the GlycanAge testing and you implement what it is that you guys recommend to do to fix the markers or to improve your markers, and then you can follow up and retest, quarterly or every year and see, okay, now where am I at, now that I've implemented these things. But like the genetic testing, it removes so much of the guesswork. Like we're all trying to constantly better our health. That's what podcast listeners, they're nutso about that kind of stuff. They always want to be, on the best supplements and the best hormones and doing the best biohacks that's going to keep them looking and feeling young. And you can spend thousands and thousands of dollars trying all of these different things. And when it comes to your genetics and this GlycanAge, you can so fine tune it for you. You can be like, okay, this is where I'm having my problems. Now let's intervene with these supplements or exercise routines or whatever it is, HRT, and then retest and see, okay, now where am I at? And it just, the amount of, I remember when I first did the genetic test, I was like, that could have, if I had done this 10 years ago, do you know how much money I could have saved on supplements? Right? Because you can be very exact for your individual system rather than just throwing the kitchen sink at yourself constantly, going, is this going to help? Is this going to help? Maybe I should take this. This sounds like it would be really good for me. And this, you can just be very targeted at what exactly it is that your body's struggling with and that's keeping you maybe at an older age.
So it's also modifiable risk factors. So anything that's in genetics, your genes will stay the same for life. And with
Right.
glycogen risk factor modifiable, they'll respond to behavioral change, to exercise, to dietary changes. They'll respond to stress as well. The stress changes up or down, and they'll respond to many medication. So it's really,
Yeah.
and it's showing you on the level of you as an individual what is the impact, because there's no one size fits all. No, there's no
Yeah.
one size fits all for any type of exercise, any diets. We really see that we need tools to personalize things to your own biology that are responsive to the interventions we're doing. So that's the use case. And if you're repeat, and the proxy is for future risk of disease and mortality, that's the um, it's what we publish in research. Commercially, we're flipping it into resilience. So your resilience to future disease and mortality, because it's positive news is always better than negative news. And every extra year above your age is increase in all-cause mortality, which is 7% for men and 4% for women. So somebody who is much older, 20, 30 years, that's a significant increased risk of disease and mortality. And somebody who's much younger, that's a significant decreased risk. And then the accuracy on repeat testing. So if you did your samples a few times in the same day, a few times in the same, the half-life is 21 days. So in the next 21 days is less than a year. So when you make a change and you see a 1-year change, that is going in the positive direction. It's not a measurement error. And actually, that's the most precise aging clock in the industry. The main problem that is with the biochemistry clocks that change on a daily basis because they're measuring things that change daily. And then with the epigenetic clocks is they don't have reliable measurement. So you can send in you can send 5 of your samples in the same day and pay a lot of money for it and get 10 years up or down, evening to morning, based on measurement error that has nothing to do with biology. So we've
Right.
really made sure that our precision is even above the clinical tools at the moment. And as we bring this into diagnostics, we are really setting a global standard for this glycan-based indications.
And mine does show some of the stuff that I see in my genetic test because my genetic test does tell me that I do have issues in the cardiovascular area. I can't remember what it was or what the SNPs were, but I remember that that was one of the ones that wasn't good as far as genetics went, is that I could be more prone to cardiovascular stuff, which I think is
Now,
so that's interesting.
and this is a very early indication for this and the time to do some investigation. I
Yeah.
can tell you a story. Obviously, it's not a diagnostic tool yet, so can't tell you your individual risk. It's just an association, like a genetic association. We're developing risk models now, so they will be in the clinic in the next year, but in hospital systems, not for consumers at this point. But one of our investors, a very young guy, I think he's 42 or maybe 43 for this year. When we tested him the first time, and he's a former athlete. He played handball for 14 years and then had a corporate career. VC, went to McKinsey, really stressful jobs. So he got his first results back, and everything else he measures was good or great, and his glycanage was horrible. It was 10, 15 years over, something like that. And then we were re-measuring him, and it was 20 years older, or closer to that, and he had these palpitations. So he would help palpitations once a month. And then he went to a number of different cardiologists, and all of them told him it's related to stress. They couldn't identify any problem. So he was recommended a holiday, and he went to the holiday, and he was driving on a motorcycle. Luckily, he was the person behind, not the person driving, and he fell unconscious. So he had palpitations and he lost consciousness. So he ended up in the hospital. They discovered what the cardio problem is. He had surgery. This is a early 40s guy. He had surgery, went well, and has improved his lifestyle a lot, particularly around stress management. And we've measured him just now recently, and his GlycanAge is his age. So we were
Oh, wow.
warning that there might be a problem. Although his initial couple of cardiology appointments missed it, and he luckily reacted on time.
Wow. That's going to
Yeah,
be
but
so gratifying when you reverse your age. When you retest and you see that it's dropped if you were above, or even if you weren't, like if I do it again after, implementing some of these things and then retest and I'm even younger, that's very satisfying.
yeah,
It's like, yes, I'm doing the good job.
and there is a path to follow. So there is room for improvement around exercise, and we can follow that. You can have feedback every 3 months. You can see a change, and then reviewing your medication. It could be a nice way to do something preventively now, although your overall age is great. Overall, your lifestyle, everything seems amazing, but there is room for improvement, and that could be the place to start.
Yeah. And we've got a coupon code for all of the listeners that you guys can get 15% off your GlycanAge test for the next month. And then it's going to go to 10%. So if you want to buy the GlycanAge test, now would be the time to do it. Use coupon code hormones. And I'm going to put all the links and coupon in the show notes. So thank you very much, Nikolina. I have been telling everybody now about the whole HRT is going to help you with your GlycanAge. And I am so pumped about this information because it's just another win for HRT and lifestyle and how powerful these things are when it comes to midlife health. So I appreciate all of your knowledge and I look forward to continuing to reverse my age.
And you're very, very welcome. Thank you for having me on the show.
No problem.